I want you to try something right now, wherever you are listening to this. Just a really quick physical challenge.
Oh, this is a great one.
Right. Okay, so take your dominant hand and fold your thumb completely flat across your palm. Like, just tuck it in.
Yeah, really flatten it out.
And now, use the fingers of your other hand to pin that thumb down right against the palm, so it is physically trapped there.
Keep it held really tight. Don't let it move.
Exactly. Now, with that thumb completely out of action, look around your environment. Try to button your shirt or, try to pick up a coin off a flat table.
Try to hold a pen and write your name.
You literally can't. It is incredibly frustrating.
Yeah.
Because in just a fraction of a second, your hand transforms from this staggeringly sophisticated tool into something entirely primitive.
You realize within about 3 seconds that the world is just completely closed off to you.
Yeah. You lose all mechanical finesse. You are essentially left with a flipper.
The clinical term I like to use for a thumbless hand is a paw. You have effectively given yourself the biological equivalent of a bear's paw.
A paw. Wow.
Yeah, I mean, you can swipe at things, you can scoop, and you can club, but you absolutely cannot manipulate.
A paw. That perfectly captures the bluntness of it, right?
Huh.
And that little physical limitation exercise is actually the exact doorway we are walking through today.
It sets the stage perfectly.
It does. Because we are doing an extensive deep dive into the engineering, the hidden biomechanics, and just the sheer biological genius of the human hand.
We're going to look at this structure through the lens of reconstructive surgery and evolutionary architecture.
Right. And we're not just going to list anatomical parts like some old biology syllabus. We really want to decode the mechanical logic.
Because the hand is arguably the ultimate triumph of human evolutionary engineering. Like, when you truly understand the architecture.
The pulleys in the sheaths, right?
Exactly. The biological pulleys, the Kevlar-like sheaths, the dedicated power grids. You stop seeing a hand and start seeing this highly strung, perfectly balanced suspension bridge.
That's a great analogy.
And to really grasp that engineering, we have to look at what happens when the cables snap and when the wiring fails. The broken machine reveals the genius of the working machine.
I love that. The broken machine reveals the working machine. But before we get into the heavy machinery of, like, tendons and bones, we need a map.
We definitely need a map.
When you look at the complex wiring of the hand, there is this master rule for the nervous system that brings everything into focus. I think we can call it the border law.
The border law is essentially the compass for this entire discussion. If you lock this into your mind, the confusing web of hand anatomy becomes remarkably elegant.
So break down the border law for us.
Okay, so the law dictates how the 3 major nerves divide the labor. It goes like this. In the hand, the radial nerve only feels.
Only feels, got it.
Right. The median nerve powers the pinch, and the ulnar nerve rules the rest.
Okay, the radial only feels, the median powers the pinch, and the ulnar rules the rest. I love the poetry of that.
It's very catchy, yeah.
So let's start at the absolute center of this evolutionary leap. Let's start with the thumb. When I pinned my thumb down earlier, you said I reverted to a paw.
Literally a paw.
But, chimpanzees and gorillas have thumbs. What exactly is the mechanical delta between a primate's grip and our ability to, say, perform open-heart surgery or play a Chopin nocturne?
The delta comes down to a tiny, very specific geometric redesign at the absolute base of the thumb.
Where exactly?
Right where your thumb's long bone, the metacarpal, meets your wrist. There is the small carpal bone called the trapezium.
Okay.
And the joint between those 2 bones is where humanity basically parted ways with the rest of the animal kingdom.
Just one joint.
Just one joint. And the secret is the shape of the cartilage there. It is a true saddle joint.
A saddle joint. Okay, so we aren't talking about a simple hinge, like the knuckles on my index finger.
Not at all.
Because a hinge just swings open and shut like a door.
Right. A hinge operates on a single plane of motion, flexion
Okay.
and extension, bending and straightening. But a saddle joint is structurally entirely different.
How so?
Picture an actual leather saddle on a horse. The seat curves downward from front to back, accommodating the rider, but it also curves upward from side to side, cupping the rider's legs.
So it's like 2 concave curves intersecting at right angles.
Exactly, intersecting at right angles.
So if one bone is the saddle, the bone resting on top of it acts like the rider's legs wrapping around it.
Yes, and that geometry allows for motion in multiple intersecting planes.
So if a hinge joint is a door swinging on a frame, a saddle joint is more like, Well, it's like the base of a joystick.
That is a brilliant analogy, a joystick.
All right, you can push it forward, pull it back, rock it side to side, and most importantly, you can sweep it in a continuous circle.
That rotational sweep is the golden ticket. Anatomists call that rotation opposition.
Opposition.
Yeah. Because of that saddle geometry, the thumb doesn't just fold downward, it swings out, away from the palm, rotates on its axis, and sweeps across the hand.
So that the fleshy pad of the thumb can directly meet the fleshy pads of any of the other 4 fingers.
It literally opposes them. Hence, opposition.
And without that rotation, without opposition, we are basically just swiping at objects. Which brings us to how anthropologists categorize what we do with our hands, right?
Yes. John Napier basically defined human interaction with the physical world through 2 fundamental grips.
So what's the first one?
Napier realized that millions of years of evolution culminated in the ability to seamlessly switch between 2 mechanical extremes. The first is the power grip.
Okay, the power grip.
Think of gripping the handle of a heavy hammer or doing a pull-up on a bar. Your fingers wrap tightly around the object, and your thumb wraps over the top of the fingers to lock them in place.
So the entire hand acts as a vice.
Exactly. The wrist locks into a rigid, neutral position to transfer the kinetic force directly up into the powerful muscles of the forearm. Chimpanzees can do this exceptionally well.
They can probably do it better than we can, honestly, if we are talking sheer crushing force.
Oh, absolutely. But the second grip is where we leave them entirely behind.
Right, Napier's second category.
Yes, the precision grip. This is where the saddle joint just shines. This is holding a scalpel or pinching a needle, turning a key in a lock.
Or just holding a pencil.
Exactly. The thumb rotates into opposition, forming a dynamic tripod with the index and middle fingers.
So the heavy muscles of the forearm quiet down.
They do. And the tiny intrinsic muscles inside the hand take over.
It's basically the difference between a sledgehammer and a pair of tweezers.
That's exactly what it is.
And the thumb is so mechanically vital to this that it functionally represents about 40% of the entire hand's utility. Just this one short, thick digit.
It really does. And because it carries almost half the workload of the human hand, the body gives it a completely dedicated power grid.
The VIP treatment.
The body spares absolutely no expense when it comes to the thumb. The other 4 fingers have to share muscle bellies in the forearm like one muscle pulls 4 tendons.
But the thumb.
The thumb has its own private staff. It has a dedicated long muscle running from the forearm just to bend the tip. It has 2 dedicated long muscles just to straighten it. And it has a massive fleshy cluster of short muscles at the base of the palm entirely devoted to moving it around the saddle.
So if anyone listening wants a quick hack for identifying anatomical structures, anytime you hear a doctor mention a muscle, tendon, or artery with the word pollicis in it, they are talking about the thumb's private staff.
Exactly. Pollicis is just Latin for thumb.
Yeah.
Flexor pollicis, abductor pollicis.
It's like a VIP tag. But here is what just fascinates me. Before we can use this incredible joystick-mounted VIP digit to thread a needle, the hand actually has to be built in the womb.
The biological manufacturing process is incredibly dark and counterintuitive.
Okay, break that down for us.
Well, the embryology of the hand defies our standard logic of how living things grow.
Yeah.
You instinctively assume that biology is additive, you know?
Right, you plant a seed, it grows a trunk, the trunk sprouts branches.
So you would assume that inside the womb, a tiny arm bud grows out, and then 5 tiny finger buds sprout from the end of it and elongate.
Like building a house by laying down bricks one by one.
But that isn't what happens at all. Around the 6th week of embryonic development, you don't have a tiny hand with microscopic fingers.
What do you have?
You have a solid, flat, homogeneous plate of tissue at the end of the arm bud. It is essentially a paddle, or a flipper.
Wait, a solid paddle. So how do we get from a flat paddle to 5 highly articulated digits?
We get there through destruction.
Destruction.
Yeah. The body doesn't build the fingers outward, it carves them out. It relies on a deeply ancient biological mechanism called apoptosis,
Apoptosis.
which translates to programmed cell death. The genetic code literally sends a self-destruct signal to the longitudinal columns of tissue located between where the future fingers will be.
Oh, wow.
Those cells die, dissolve, and are reabsorbed, leaving the fingers behind.
Okay, I have to stop and ask. Why? Why would evolution design such a morbid, inefficient system?
It does seem crazy, right?
Yeah. Why build an entire paddle of living tissue just to aggressively kill half of those cells a few weeks later? Why not just sprout the fingers in the first place? It feels like building a solid block of marble just to chisel it away.
Because from a genetic programming standpoint, chiseling is vastly more reliable than independent sprouting. Evolution is a tinkerer. It works with the legacy code it already has.
Okay.
The blueprint for vertebrate limb bud is millions of years old. It starts as a solid mass. It is genetically much simpler to establish a gradient of a protein, like the famous Sonic Hedgehog protein, to lay down a basic pattern and then tell the filler tissue to die.
Rather than trying to coordinate 5 independent stalks growing outward at the exact same speed.
Exactly. Maintaining the exact same spacing, perfectly synchronizing their joints, it's too much risk.
Ah, I see. If 5 fingers are sprouting independently, there is a massive risk that one grows sideways or one grows twice as fast as the others. By carving them out of a single block, the spacing and alignment are guaranteed by the mold itself. It's like a stamp.
Precisely like a stamp. Apoptosis is a remarkably conserved evolutionary tool. It is the exact same cellular command that removes the webbing between a tadpole's toes when it transitions into a frog.
That is mind-blowing.
Yeah.
But as with any complex biological software, you have to ask, what happens when there is a glitch in the code?
Right.
What happens when the biological sculptor's chisel slips or forgets to fire?
If the cells between the fingers don't receive the self-destruct signal, they just stay there. They keep growing.
And clinically, this manifests as a congenital condition called syndactyly.
Yes. A child is born with webbed fingers. The digits themselves, the bones and tendons, might be perfectly formed, but they are encased in a single envelope of skin because the apoptosis failed to separate them.
Which means when a pediatric reconstructive surgeon operates to separate those fingers, they aren't really fixing a broken structure.
No, not at all.
They are quite literally stepping in to manually finish the exact cellular job that the embryonic software failed to complete. They become the sculptor.
That is a perfect way to conceptualize it. And there is another common software glitch called polydactyly, where the body miscalculates the pattern itself.
And forms an extra digit. Right.
Yeah, usually a smaller extra finger sprouting off the side of the little finger.
Incredible. But once this intricate structure is finally sculpted, whether by biology or by a surgeon, we face a massive engineering problem.
The power supply problem.
Right. Let's dive into that.
Okay, so the muscles that generate the massive crushing force of the power grip are too large to fit inside the hand itself.
If they were in the hand, your palm would be the size of a grapefruit, and you would have zero dexterity.
Exactly. So the body placed those heavy motor units far up in the forearm.
Like putting the heavy engine of a crane down at the base
Yeah.
and just running steel cables up the long arm to do the actual lifting.
Yes. But every single one of those cables, the tendons, along with the delicate nerve wires and the arterial plumbing, has to cross the wrist joint to get to the fingers.
Which creates an absolute biomechanical nightmare of a bottleneck.
Let's dive into that bottleneck, because understanding the architecture of the wrist unlocks one of the most famous and misunderstood medical conditions in the modern world.
How does the body route all this hardware across a bending joint?
To understand the wrist, hold your hand out, palm up, and visualize the bones. You have 8 small, pebble-like carpal bones,
Okay.
but they don't lay flat like tiles on a floor. They are arranged in a specific geometry. They curl upward at the outer edges, forming a deep, concave gutter running straight down the center of the wrist.
It forms a biological half-pipe.
A half-pipe is the perfect analogy. The bones form the rigid floor and the walls of this trench. Now, if you just ran the tendons through that open trench, every time you forcefully bent your wrist forward, the tendons would bowstring.
They would pop straight up out of the trench, stretching your skin like guitar strings.
So you have to tie them down. You need a roof over the half-pipe.
And the body provides a remarkably tough roof, right?
It does. It is a thick, unyielding, fibrous band of ligament called the flexor retinaculum. It straps tightly across the tops of the carpal bones, sealing the gutter shut.
And by putting a flat, rigid roof over a curved, bony gutter, you have instantly created a tunnel,
The carpal tunnel.
the carpal tunnel. It is a high-security anatomical checkpoint, and the guest list is completely non-negotiable.
Totally rigid. Inside that incredibly tight, rigid space, the body packs exactly 10 structures.
Let's audit the guest list. We have 9 cables,
Yeah.
9 tendons.
Oh.
4 tendons dive deep to bend the final tips of your forefingers. 4 more sit just above them to bend the middle joints of those fingers.
All right.
And 1 dedicated massive tendon passes through to flex the thumb. So that's 9 physical cables gliding back and forth constantly. And right on top of them, pressed right up against the roof, is our first major nerve,
The median nerve. Let's recall our border law. The median nerve powers the pinch.
Right. It is the electrical conduit that gives you opposition of the thumb and feeling in the primary working pads of your fingers.
So my analogy for the carpal tunnel is an underground subway car during a humid midsummer rush hour.
Oh, that sounds miserable.
It is. You have 10 passengers crammed into a steel tube. The walls are bone, the roof is thick ligament. Nothing can stretch, nothing can yield. Under normal resting conditions, it's a tight fit, but it works.
The tendons just glide past each other in their slippery sheaths.
But what happens when the conditions aren't normal? What happens when a person spends 8 hours a day, 5 days a week, violently striking a keyboard or operating a vibrating jackhammer?
Or gripping a factory assembly tool. Friction.
Friction, the constant mechanical friction of those 9 cables rubbing inside their sheaths causes inflammation. And when biological tissue gets inflamed, it swells, it pulls in fluid.
Now play that out inside your subway car. The 9 tendons begin to swell. They expand. But the floor is solid bone, and the roof is an unyielding ligament.
The tunnel physically cannot get any larger to accommodate the swelling. The pressure inside this closed compartment steadily skyrockets.
And the swelling inevitably targets the softest, most vulnerable passenger in the car.
The median nerve, it gets crushed against the roof. The medical term is ischemia. When the pressure inside the tunnel exceeds the pressure of the tiny blood vessels feeding the nerve, the blood flow stops.
So the nerve begins to suffocate.
It is literally starving for oxygen.
Yeah.
And a suffocating nerve protests violently.
Which manifests as carpal tunnel syndrome. Numbness, burning, tingling.
And importantly, it only affects the specific territory the median nerve covers. The thumb, the index finger, the middle finger, and exactly the thumb side half of the ring finger.
I always found that so fascinating. It splits the ring finger perfectly down the middle.
That razor-sharp dividing line on the ring finger is how you know you are looking at a hardwired neurological map. And one of the hallmark symptoms of carpal tunnel syndrome is that the pain is worse at night.
Patients will tell you they wake up at 3 a.m. feeling like their hand is on fire, shaking it out over the side of the bed. But why does it happen at night? You aren't typing in your sleep.
It actually comes down to sleeping posture. Most people naturally curl into a fetal position when they sleep, and that includes flexing their wrists tightly inward.
Ah, okay.
When you flex the wrist to 90 degrees, you aggressively compress the volume of the carpal tunnel. You are taking a subway car that is already overpressurized and actively squeezing the walls together.
Which is exactly the mechanic behind one of the primary physical tests doctors use to diagnose it, right?
Yes, Phelan's maneuver. If you are listening right now, you can do this.
Yeah, walk us through it.
Press the backs of your hands together in front of your chest, forcing your wrists to bend sharply downward at a harsh 90-degree angle. It looks like a reverse prayer position.
Okay, I'm doing it.
A doctor will ask a patient to hold that awkward posture for a full 60 seconds.
You are artificially recreating the worst possible conditions for the tunnel.
Exactly. You are mechanically maximizing the squeeze. If the median nerve is already inflamed and sitting on the edge of ischemia, 60 seconds in Phelan's position will push it over the edge.
The numbness and tingling will just come roaring into the fingertips.
Now, there is another test that sounds almost cruel, called Tinel's sign.
Tinel's is very direct. The physician simply takes their fingers and firmly taps directly over the roof of the carpal tunnel on the patient's wrist.
Just tapping on it, yeah.
If the nerve is healthy, you just feel a dull tap. But if the nerve is highly sensitized and crushed, that physical percussion will trigger a sudden, violent jolt of electricity that shoots straight down into the thumb and index finger.
It's the exact same mechanic as hitting your funny bone at the elbow, just relocated to the wrist.
So if the subway car is completely compromised and the nerve is dying, what is the surgical fix?
You have to alter the architecture. You perform a carpal tunnel release. The surgeon makes an incision in the palm, navigates down to the thick fibrous roof, the flexor retinaculum, and literally cuts it in half.
Wow.
You slice the roof open, completely destroying the tunnel. The two halves of the severed ligament instantly spring apart, releasing the pressure. The subway car is now an open-air train.
So the nerve breathes again.
Blood flow returns, and over time, the gap in the ligament fills in with slightly looser scar tissue, permanently expanding the volume of the space.
It is such a brutal but brilliantly effective mechanical solution to a mechanical problem. But here is a diagnostic mystery about carpal tunnel that I absolutely love because it highlights the genius of how the body runs its wiring.
Oh, this is good.
If the median nerve is completely suffocating inside that bony tunnel, Why doesn't the entire palm of the hand go numb?
It is one of my absolute favorite details in human anatomy. It shows you the elegance of the system.
Right, because patients with carpal tunnel have numb fingers. But if you prick the thick skin of their central palm with a pin, they feel it perfectly. The palm is completely spared. How is that mathematically possible if the main power cable is crushed?
Because the body built an escape hatch.
And it's escape hatch.
Yes, the massive main trunk of the median nerve has to dive into the dark, rigid tunnel to get to the fingers. But just a few centimeters before it enters the danger zone, it gives off a tiny, almost invisible microscopic branch.
A dedicated sensory twig purely for the skin of the palm.
A VIP exit right before the bottleneck. And this tiny palmar skin branch doesn't go through the tunnel. It stays superficial. It flies right over the top of the retinaculum roof.
It completely bypasses the crush zone.
Exactly. So when the pressure inside the tunnel skyrockets and suffocates the main nerve trunk, this little skin branch is happily floating above the chaos, completely safe and unimpeded.
So the palm keeps its feeling. And from a diagnostic perspective, that is a flawless biological fingerprint.
Flawless.
If I'm a doctor and a patient says, my thumb and index finger are numb, but my palm feels perfectly normal, I know with absolute certainty that the pinch point is happening specifically inside the carpal tunnel.
Exactly. It isolates the location of the lesion. Now, conversely, what if the patient says their thumb is numb and the entire palm of their hand is completely dead to sensation?
Then the carpal tunnel isn't the primary problem. The crush must be happening much higher up the arm, maybe at the elbow or the neck, before that tiny escape hatch branch ever had a chance to split off.
Yeah.
It's like diagnosing a plumbing issue. If the kitchen sink and the bathroom sink are both dry, the break is in the main water main in the street. If only the bathroom is dry, the break is under the bathroom floor.
That is exactly how a neurologist thinks. You read the map by seeing what is broken and what is spared.
Now, we mentioned the median nerve. What about the ulnar nerve, the one that rules the rest? Is it suffering in the carpal tunnel too?
The ulnar nerve avoids the carpal tunnel entirely. It runs down the little finger side of the arm, and it has its own private parallel doorway at the wrist right next door to the carpal tunnel. It's called Guillen's Canal.
So they have separate entrances.
They do. Guillen's Canal sits superficially, actually resting on top of the carpal tunnel's roof. This means a severe crush inside the carpal tunnel completely spares the ulnar nerve.
Oh, that makes sense.
However, Guillen's Canal has its own unique vulnerabilities. It is very exposed to direct external pressure. If you are an avid long-distance cyclist and you lean your heavy body weight entirely on the outside heels of your hands against the handlebars for 50 miles, you can crush the ulnar nerve against the floor of Guillen's Canal.
Cyclist palsy. You get off the bike and your little finger and ring finger are completely numb.
Exactly. A localized crush of the ulnar nerve. But before we successfully navigate past the wrist and spill into the palm, we have to flip the hand over. There is a hidden architectural landmine on the back of the wrist that terrifies trauma surgeons.
You are talking about the anatomical snuff box, which is objectively one of the greatest names in all of anatomy.
It is a phenomenal name, and it refers to a very specific topographic hollow. If you forcefully extend your thumb cock aggressively backward like you were trying to hitchhike, you will see a pronounced triangular depression form on the back of your wrist right at the base of the thumb.
It is bordered by two taut V-shaped tendons. I'm doing it right now. The tendons pop up like guitar strings, and a distinct little bowl forms between them.
Historically, in the 18th and 19th centuries, gentlemen would use that exact anatomical depression to place a small mound of powdered tobacco snuff before raising it to their nose to inhale it.
Thus, the anatomical snuff box.
Exactly.
Okay, a quirky historical artifact. But why does this little hollow strike fear into the hearts of surgeons?
Because of the bone that forms the floor of that hollow. If you take your opposite index finger and press deeply into the center of your snuff box, you are pressing directly onto a small, peanut-shaped wrist bone called the scaphoid.
And the scaphoid represents a massive evolutionary oversight.
A huge oversight.
Yeah.
Imagine you are walking on an icy sidewalk. You slip, you lose your balance, and you fall forward. Instinctively, what do?
You throw your arm out, lock your wrist backward, and brace for impact. You fall on an outstretched hand.
Right. Your entire body weight, plus gravity, crashing down onto one joint. And the physics of that impact dictate that the kinetic force travels straight up from the heel of your hand directly into the scaphoid bone. It acts as the primary shock absorber.
And because of its awkward shape and position, it fractures incredibly easily across its narrow waist. It snaps in half.
Okay, A broken wrist bone. That sounds painful, obviously, and it ruins your ski trip. But bones break all the time. You put a cast on it, and 6 weeks later, it's fine. Why is a scaphoid fracture a surgical emergency?
Because of the scaphoid's blood supply.
Yeah.
It is entirely backwards.
Wait, backwards blood supply? That sounds like a catastrophic design flaw. Why would evolution do that?
It is a massive structural flaw, likely a byproduct of how the carpal bones rotate and develop in the womb.
Yeah.
In almost every bone in your body, the blood vessels enter near the center or the top and flow downward. But in the scaphoid, the primary artery enters at the very far end, the distal pole closest to the fingers, and the blood then has to flow backwards proximally toward the wrist to feed the top half of the bone.
Oh, I see the geometry of the disaster here. If the impact snaps the bone directly across the middle.
You completely sever the vascular highway. The bottom half of the bone still has its blood supply entering from the distal end, so it survives. But the top half of the bone is suddenly completely isolated. No blood can cross the fracture line.
So it's not just a broken bone. Half of the bone is actively starving to death.
Precisely. The clinical term is a vascular necrosis, death by lack of blood flow. Without a massive surgical intervention to pin the bone back together and attempt to restore vascularity, that top fragment of the scaphoid will literally die, crumble into dust, and catastrophically destroy the biomechanics of the entire wrist joint.
Wow. The patient will be left with early onset, crippling arthritis.
That is terrifying. So if I fall on the ice, I go to the ER and they take an x-ray. It should be obvious, right?
This is the most insidious part. A scaphoid fracture is notorious for hiding. On day 1, right after the fall, the fracture line can be so impossibly fine, so hairline, that it does not show up on a standard two-dimensional x-ray. The film looks perfectly pristine.
So the ER doctor might tell you it's just a bad sprain.
But the bone is quietly dying in the background.
How does a doctor prevent that?
They rely on the physical exam, they relied on the snuff box. This is a golden rule taught in every medical school. If a patient falls on an outstretched hand and they have deep localized tenderness when you press firmly into their anatomical snuff box, it is considered a scaphoid fracture until proven otherwise.
You ignore the clean x-ray.
You entirely ignore the clean x-ray. You treat the physical symptom. You put the patient in a rigid thumb spica splint or a cast immediately, immobilizing the joint, and you demand they return in 10 days for a follow-up x-ray.
Oh, because by day 10.
By day 10, if the bone is broken, the body's natural inflammatory process will have resorbed a tiny bit of bone along the edges of the fracture, widening the gap. Suddenly, the invisible fracture appears clearly on the film. You catch it before the avascular necrosis becomes irreversible.
That is a phenomenal piece of diagnostic logic. You treat the mechanical reality, not the snapshot. Okay, so we have survived the bottlenecks. The tendons have navigated the carpal tunnel, the ulnar nerve slipped through Bigon's canal, and the scaphoid is intact. The cables and wiring finally spill out onto the factory floor, the palm.
The working face of the machine.
But the first thing these delicate structures encounter when they enter the palm isn't muscle. Right beneath the skin is a dense triangular sheet of tissue called the palmar aponeurosis.
We talked earlier about the crushing power of the power grip, wrapping your hand around a heavy hammer and swinging it. The aponeurosis is the hidden anchor that makes that physical action possible without ripping your skin off.
Explain the physics of that.
Let's do another physical exercise. Take your opposite hand, pinch the loose skin on the back of your hand, and wiggle it around.
Okay, I'm doing it. The skin is incredibly mobile. I can slide it almost an inch in any direction over my knuckles.
Exactly. It's built for elasticity, to stretch when you make a fist. Now, try to do the exact same thing to the thick skin right in the center of your palm. Try to pinch it and slide it.
You can't. It is completely locked down. It feels glued to the deeper tissues.
It is glued down. And the glue is the palmar aponeurosis. It is a thick, unyielding sheet of fascia that sends millions of tiny fibrous bands up into the dermis of the palm, tethering the skin tightly to the deeper structural skeleton of the hand.
If you didn't have that aponeurosis, the sheer friction of swinging a heavy hammer would cause the skin of your palm to slide right off the underlying tissue, like a loose glove slipping off your hand.
It's like a biological Kevlar plate. It tethers the grip and acts as a rigid shield protecting the delicate nerves and blood vessels diving underneath it.
But this protective Kevlar plate has a dark side. It can turn into a villain.
It can. There is a notoriously aggressive disease associated with this exact sheet of tissue called Dupuytren's contracture. It is named after Baron Guillaume Dupuytren, who was a brilliant, wealthy, and reportedly incredibly arrogant Parisian surgeon in the early 1800s.
It feels oddly appropriate that an arrogant surgeon gets a hand-mangling deformity named after him. How does the disease work?
In Dupuytren's contracture, the fibroblasts, the cells that maintain this flat sheet of fascia go rogue. They begin overproducing collagen. The normal, flat, protective sheet begins to thicken and mutate. It forms these hard, painful nodules under the skin of the palm.
Okay.
Over years, those nodules organize into thick, rigid, rope-like cords that run longitudinally down toward the fingers.
And as those cords thicken,
They shrink. They contract. They act exactly like biological winch cables slowly tightening. And because the aponeurosis is tethered to the fingers as the cords shorten, they physically haul the fingers, most aggressively the ring and little fingers downward, locking them into a permanently bent position against the palm.
so it's not a joint problem and it's not a tendon problem. It's the fascia acting like a tightening net.
Exactly. The underlying flexor tendons are actually perfectly healthy, gliding right beneath the diseased cords, but the patient physically cannot straighten their fingers no matter how much force they apply, because the structural scaffolding above them has turned to stone.
Incredible. Okay, if we peel back that Kevlar aponeurosis, if we get past Dupuytren's shrinking net, we finally hit the massive muscle groups of the palm.
And diving into these intrinsic muscles usually overwhelms medical students.
There are so many of them crammed into such a small space. You have the thenar group at the thumb, the hypothenar group at the pinky, and the central group packed between the bones. We need our life raft here. Bring us back to the border law to make sense of this wiring.
The border law makes the chaos evaporate. Remember, the radial nerve only feels. It is out of the motor game completely once we pass the wrist, so we only have two power sources left to operate every single tiny motor inside the hand: the median nerve and the ulnar nerve.
The median and the ulnar.
Let's start with the median nerve. The median powers the pinch. Here is the master rule of the palm. The median nerve supplies the fleshy muscular mound at the base of the thumb, the thenar muscles, and it supplies two tiny worm-like muscles attached to the index and middle fingers called the lumbricals.
And that's it.
That is it. That is the entire muscular territory of the median nerve in the hand. The base of the thumb and two tiny worms on the index and middle fingers.
But logically, that makes perfect sense. If its evolutionary job is to power the precision grip, the pinch, then it only needs the thumb and the two fingers that oppose the thumb.
Exactly.
It is a highly specialized, isolated power grid just for holding a pen or threading a needle.
Exactly. It operates the tripod. Now, if the median nerve only operates the thumb and two lumbricals, what does the ulnar nerve operate?
The ulnar rules the rest. So the ulnar nerve is the mastermind behind everything else.
Literally everything else. It powers the hypothenar muscles at the base of the little finger. It powers all the other lumbricals. It powers the massive adductor muscle that snaps the thumb shut. And most importantly, it powers the interossei muscles, the tiny muscles packed deep between the metacarpal bones.
The ulnar nerve is the undisputed king of the palm. It is the nerve of complex dexterity.
If the median nerve is about precise static pinching, the ulnar nerve is about dynamic fluid manipulation. Let's look at those deep interossei muscles, because the mechanics of how they move the fingers sideways is brilliant.
To understand sideways movement, medical students use a classic, foolproof mnemonic, right? PAD and DAB. PAD and DAB.
Let's break down the mechanics of PAD and DAB. Let's do it physically. Put your hand flat on a table in front of you. Spread your fingers apart. Now, forcefully squeeze all your fingers tightly together, as if you were trying to hold a sheet of paper clamped between your index and middle fingers.
Okay, fingers squeezed tight.
The muscles doing that squeezing are the palmar interossei. The mnemonic is PA, palmar interossei adduct. In anatomy, to adduct means to pull toward the midline. The palmar muscles live on the front of the bones, and their mechanical vector pulls the fingers inward, squeezing them shut.
So, PA, palmar adducts, squeezing together. What about DAB?
Keep your hand flat on the table and now aggressively splay your fingers as wide apart as they will go, stretching them out like a starfish.
Splayed wide.
The muscles fighting against the tension to spread your fingers are the dorsal interossei. The mnemonic is DAB, dorsal interossei abduct. To abduct means to pull away from the midline, like an alien abduction taking you away. The dorsal muscles live on the back of the bones, and their vector pulls the fingers apart.
So if my ulnar nerve gets severed in an accident, say I smash my elbow through a glass window and cut the nerve, what happens to my hand mechanically?
The PDAs and DABs instantly die. You completely lose the ability to squeeze your fingers together or splay them apart. Your fingers become entirely floppy in the horizontal plane. You could not hold a cigarette between your fingers, and you could not stretch your hand to play a wide chord on a piano.
But the loss of the ulnar nerve is so much more devastating than just losing sideways wiggling. Because those P80DAB muscles aren't just for movement. They are structural support columns. Which brings us to the concept of the vault.
This is where we shift from biology to civil engineering. The human hand is not a flat board. It is a highly tensioned, three-dimensional dome. If you completely relax your hand right now and look at it, you will notice it naturally forms a cupped shape.
Right, there's a hollow in the center of the palm.
That hollow is created by three distinct intersecting structural arches. You have a rigid transverse arch running horizontally across the carpal bones at your wrist. You have a mobile transverse arch running horizontally across your knuckles. And you have longitudinal arches running down the length of every single finger.
When you weave those three arches together, you create an architectural vault.
A geodesic dome. And that dome shape is what allows me to go to the sink, turn on the tap, and naturally cup a pool of water in my hands without it spilling out the sides.
Exactly. But a dome is an active architectural structure. It requires constant balanced tension to maintain its shape against gravity and external forces. The keystones that maintain that structural tension, that hold the arches in their cupped posture, are those tiny intrinsic muscles, the interulsae and the lumbricals.
The muscles powered by the ulnar nerve.
Yes. So we return to the scenario where the ulnar nerve is severed, the power is cut. The PTAs, the DABs, and the lumbricals paralyze. What happens to the geodesic dome?
The keystones fail. The tension vanishes, the arches collapse, the vault falls down.
The vault violently collapses. The entire hand flattens out into a board. But because the massive forearm muscles are still pulling on the tendons without any intrinsic muscles to balance them, the hand violently distorts. The knuckles yank aggressively backward and the finger joints curl tightly inward. The hand transforms into a rigid, paralyzed claw.
A claw. We are going to dive deeply into the mechanics of that claw later, but the visualization of the hand as a collapsed vault is staggering. Before we leave the palm, we have to talk about the physical maintenance of this factory floor, because keeping this complex machinery alive requires a massive redundant supply of oxygen.
The hand is highly vascularized, an evolution built in a brilliant fail-safe mechanism. The hand actually has two major arterial loops, or arches, crossing the deep tissues of the palm to ensure the fingers never ever starve for blood. You have the superficial palmar arch, fed primarily by the ulnar artery, and the deep palmar arch, fed primarily by the radial artery.
It is a closed-loop system, a backup generator.
Precisely, and this redundancy is heavily utilized by modern medicine. Say you are in the intensive care unit, and a doctor needs to insert an arterial line directly into your radial artery to constantly monitor your blood pressure. Or a cardiac surgeon wants to physically harvest a piece of your radial artery to use for a heart bypass surgery. Before they ever touch that radial artery, they have to guarantee that the backup generator, the ulnar artery, can handle the entire workload of the hand alone.
They have to test the plumbing, and they do it with a brilliant bedside check called the Allen's test. If you are listening, you can basically do a modified version of this to yourself right now.
To perform an Allen's test, the doctor takes their thumbs and presses down aggressively on both the radial artery and the ulnar artery on the inside of your wrist, completely crushing them flat and stopping all blood flow to the hand.
While they hold the pressure, they tell you to aggressively pump your fist open and shut 5 or 6 times. You are literally wringing the remaining blood out of your hand. When you finally open your hand, your palm will look ghostly pale. It is completely white and bloodless.
Then comes the moment of truth. The doctor releases their thumb from the ulnar artery only, keeping the radial artery firmly pinned shut.
And they watch the palm.
They watch the palm closely. Within about 3 to 5 seconds, a vibrant wave of pink color should rush back across the entire surface of the hand all the way to the fingertips. It is visually dramatic. The ulnar artery is rushing in, crossing the palmar arches, and backfilling the entire system to fill the void left by the crushed radial artery.
If the hand pinks up rapidly, the test is positive. The backup generator is flawless, and the surgeon knows they can safely harvest the radial artery without amputating the hand.
It is a simple, elegant mechanical test of biological fluid dynamics. But while the vascular system is robust, the palm has a massive vulnerability when it comes to pathogens.
Infections. The surgical notes treat infections in the hand with a level of fear usually reserved for cardiac arrests.
For good reason. Deep inside the palm, beneath the Kevlar aponeurosis, the space is divided into deep, cavernous fascial compartments. The thenar space, the mid-palmar space, And surrounding every single flexor tendon is a closed, double-walled biological tube called a synovial sheath, filled with lubricating fluid.
Like a greased sleeve that allows the tendon cable to glide back and forth without friction.
Exactly. Now imagine a seemingly innocuous injury. A gardener gets pricked deep in the finger by a dirty rose thorn, or someone gets bitten by a cat. That deep puncture wound acts like a hypodermic needle, injecting aggressive bacteria directly into the enclosed space of that synovial sheath.
Bacteria absolutely thrive in dark, warm, enclosed, fluid-filled spaces.
They multiply exponentially. And the clinical result is a flexor tenosynovitis, a severe infection of the tendon sheath. To diagnose this, surgeons rely on the gospel of Alan Canavel, a legendary pioneer in hand surgery who identified 4 cardinal signs of a flexor sheath infection.
Canavel's 4 signs. Let's walk through them, because missing these is a catastrophic malpractice error.
Sign number 1, fusiform swelling. The entire affected finger swells up completely evenly, losing all of its natural contours. It takes on the exact shape of a cocktail sausage.
Sign number 2, posture.
The patient will hold the infected finger in a rigid, slightly bent resting posture. Why? Because the sheath is rapidly filling with pressurized pus. Bending the finger slightly creates the maximum volume inside the sheath, giving the pus room to exist.
Which perfectly sets up sign number 3.
Extreme tenderness, but not just at the site of the rose thorn prick. If the doctor presses gently along the entire length of the tendon, dragging their finger down into the palm, the patient will experience acute pain because the infection has traveled down the entire length of the closed tube.
But it is Canavel's 4th sign that is the true ticking time bomb, the hallmark symptom.
The 4th sign is excruciating, screaming pain on passive extension. If the doctor takes that slightly bent sausage-like finger and very gently tries to passively straighten it out.
By straightening it, you are physically stretching a tendon that is actively stewing in a closed, pressurized tube of inflammatory fluid. The pressure skyrockets. The patient will literally jump off the exam table.
They will. And if an ER doctor sees these 4 signs and casually dismisses it as a simple bug bite, prescribing some oral antibiotics and sending them home, they have doomed that patient's hand.
Because it is a pressure cooker. Explain the mechanics of why the tendon dies.
Tendons have an incredibly fragile blood supply. As the bacteria multiply, the pus expands, but the fibrous walls of the sheath cannot stretch. The pressure inside the tube rises exponentially until it surpasses the arterial pressure feeding the tendon.
Ischemia again. Just like carpal tunnel, but localized inside a finger.
Exactly. The blood flow stops entirely. Within hours, the tendon begins to starve, rot, and necrotize. Once a flexor tendon dies and snaps, it is gone forever. You permanently lose the ability to bend that finger. That is why Canavel's signs dictate an immediate, same-day trip to the operating theater. The surgeon must slice the sheath open, wash the pus out with liters of saline, and relieve the pressure to save the mechanical cables.
Incredible. Okay, we have explored the heavy machinery of the palm, the Kevlar plates, the massive motor groups, the tension vaults, the pressurized tubes. It is time to flip the hand over. We are moving to the dorsum, the back of the hand.
It is an entirely different universe on the back of the hand.
It really is. If the palm is built like a diesel truck engine, the back of the hand is built like a Swiss watch. If you look at the back of your hand right now, it is almost entirely devoid of muscle. The skin is paper thin and loose. You can plainly see the veins, and when you wiggle your fingers, you can watch the long extensor tendons gliding visibly just beneath the surface, like bare suspension cables.
The dorsum is entirely dedicated to elegant mechanical transmission. Remember, the massive muscles required to generate force are up in the forearm. They send these long, naked cables down across the back of the hand to reach the fingers. But tendons are dumb ropes. They can only do one thing: pull in a straight line. So how do you take a dumb rope and use it to execute the impossibly complex, multi-joint articulation of a human finger?
You have to build a transmission system.
Yes, and the true architectural genius of the back of the hand is a structure called the extensor expansion, also known as the dorsal hood.
The dorsal hood. I struggled with visualizing this initially, but once you map it out, it is astonishing. Walk us through the anatomy of this hood.
Picture that long, bare extensor tendon traveling down the back of your hand from the wrist. When it reaches the main knuckle, the metacarpophalangeal joint, it doesn't just attach to the bone like a normal cable. It flattens out, widens, and transforms into a triangular sheet of fibrous tissue that drapes entirely over the knuckle, almost like a miniature superhero cape or a hood.
Okay, a fibrous hood wrapping over the top and sides of the knuckle.
From the tip of that hood, the tissue splits into 3 distinct straps, or slips. The central strap travels straight down the exact middle of the finger and anchors securely into the base of the middle bone. Its job is to straighten the middle joint.
And the other two straps?
The two lateral side straps bypass the middle joint completely. They slide down the sides of the finger, merge back together into a single point, and anchor into the very final bone at the absolute tip of the finger. Their job is to straighten the final distal joint.
My analogy for this is a theatrical marionette rig. You have one master string, the long forearm muscle pulling from above, but that master string connects to a complex wooden crossbar, the hood, which then uses multiple secondary strings to operate different independent joints down the chain.
That is a brilliant mechanical analogy, a marionette rig. But here is the massive plot twist. Here is the paradox that makes human dexterity possible. Those tiny intrinsic muscles we discussed earlier, the lumbricals and the interosseous, the ones living on the palm side of the hand.
The keystones of the vault.
Yes. Their tendons do not attach to the palm side of the fingers. They travel up, wrap tightly around the sides of the knuckles, and insert directly into the edges of this back-of-the-hand dorsal hood.
Wait, I have to pause and process the physics of that. So you have a muscle located on the front of the hand pulling on a complex strap mechanism located on the back of the hand.
Yes, and because of that bizarre wraparound insertion point on the hood, when those intrinsic lumbrical muscles fire, they do something mathematically paradoxical. The vector force pulls the base of the hood downward, forcing the main knuckle to bend sharply forward in deflection. But simultaneously, that exact same pull tightens the central and lateral straps of the hood, which forces the middle and tip joints of the finger to lock completely straight.
It bends the knuckle while simultaneously straightening the finger.
Exactly. Picture yourself making a shadow puppet of a dog snapping its mouth shut. Or picture how your hand looks when you are gripping a thick, heavy textbook from the top spine. Your knuckles are bent at a sharp 90-degree angle, but your fingers themselves are perfectly rigid and straight.
That specific simultaneous posture knuckle bent, finger straight, is biologically impossible without the intrinsic muscles balancing the dorsal hood.
It is impossible. And this entirely explains the terrifying mechanism of the ulnar claw we talked about earlier. Let's revisit the collapsed vault. When the ulnar nerve dies, the intrinsic lumbrical muscles paralyze. They stop pulling on the dorsal hood.
The marionette crossbar loses its anchors.
Exactly. The delicate balance of tension is instantly destroyed. The massive, dumb forearm muscles take over completely unopposed. Because the hood is no longer held in check, the forearm muscles yank the main knuckle violently backwards into hyperextension, pulling the finger up toward the ceiling. But because all the tension is lost in the secondary straps, the middle and tip joints collapse forward into a tight curl.
Knuckles bent backwards, fingers curled tight inward, the claw. It isn't just a random deformity, it is the visual manifestation of a mathematical vector system falling wildly out of balance.
It is pure physics. But nerve damage isn't the only thing that can destroy the hood. The physical straps of the marionette rig can snap from trauma. And when they do, surgeons use very specific, wonderfully descriptive names for the resulting deformities.
Let's do a deep biomechanical analysis of these hood failures. The first one is incredibly common in sports. Mallet finger.
Imagine you are playing basketball. Someone throws a hard pass, you misjudge it, and the heavy ball jams directly into the absolute tip of your outstretched index finger.
A classic jammed finger.
The immense force violently bends the tip of the finger downward, but the long forearm muscle is simultaneously trying to pull the tip straight. The force of the basketball wins. The two lateral straps of the dorsal hood, the ones that travel all the way to the end to extend the tip, are physically ripped away from the bone. They snap.
So the marionette strings controlling the final joint are severed.
Yes. The clinical presentation is immediate and undeniable. The patient can bend their finger perfectly fine, but the very tip of the finger droops downward at a 45-degree angle, entirely limp. They physically cannot straighten it, no matter how hard they try. It hangs down, looking exactly like the head of a wooden mallet.
Mallet finger. Okay, that's the final strap snapping. What happens if the trauma hits the center of the rig? What if the central strap snaps?
If you forcefully jam the middle joint of the finger, say, falling hard on a bent knuckle, you can rupture that central slip, the one that anchors to the middle bone. This creates a fascinating and disastrous mechanical cascade.
Walk us through the cascade.
The central slip snaps. The middle joint instantly loses its ability to straighten, so it collapses downward into a bent position. But remember, the two lateral straps are still intact on the sides. Because they are no longer held together by the central tension, they start to slip downwards, sliding off the top of the knuckle and migrating down the sides of the finger.
Like the straps of a backpack slipping off your shoulders.
That is the perfect analogy. And as those lateral straps slip below the axis of the joint, their mechanical vector completely reverses. Instead of having to pull the finger straight, they now actively act as flexors, pulling the middle joint even tighter into a severe bend. The middle joint physically pops up and forces its way through the gap between the slipped lateral bands.
It pushes through the gap, like a button pushing through a buttonhole.
Exactly. Which is why this specific structural failure is globally known as a boutonniere deformity. Boutonniere is French for buttonhole. The joint has literally buttoned itself through the ruptured extensor hood.
The mechanics of that are so intricately devastating. And there is one more classic hood deformity that is essentially the mirror image of the boutonniere, right?
Yes, the swan neck deformity. We typically see this not from blunt trauma, but from the chronic systemic joint destruction of severe rheumatoid arthritis. In a swan neck, the inflammatory disease stretches out the ligaments on the palm side of the middle joint. The joint becomes unstable and hyperextends violently backwards.
So it bends the wrong way.
Right. And as the middle joint snaps backward, it mechanically pulls all the tension out of the lateral straps going to the tip. Because those straps go slack, the tip of the finger drops limply downward. So you have a middle joint bent aggressively backward and a tip drooping forward.
It looks exactly like the curved, graceful neck of a swan. Again, these aren't just random shapes. They are the predictable geometrical consequences of the marionette rig failing at specific tension points.
Exactly. Before we move completely away from the back of the hand, we have to look back at the wrist. The extensor cables have to cross the back of the wrist joint, and just like the palm side, they need a roof to prevent bowstringing.
So there is a dorsal retinaculum as well.
There is. But unlike the massive single-cavern carpal tunnel on the front, the back of the wrist is highly organized. The dorsal retinaculum is divided by vertical walls of tissue into 6 distinct miniature tunnels or compartments. Each compartment acts as a highly specific pulley system for a different set of tendons.
And the compartment that causes the most clinical trouble is the very first one, right on the edge of the thumb.
The first dorsal compartment. It is a tiny, incredibly tight tunnel that houses 2 specific tendons, the ones that pull the thumb backward away from the palm. And because this tunnel is so tight, it is highly vulnerable to overuse and friction, resulting in a brutally painful condition called de Quervain's tenosynovitis, named for the Swiss surgeon Fritz de Quervain.
The surgical notes highlight that this condition is wildly prevalent in one specific demographic: new mothers. Why is a new mother so susceptible to a ruptured pulley in her thumb?
Think deeply about the repeated physical mechanics of caring for a newborn. A baby is in a crib. To lift them, you reach down, slide your hands beneath their armpits, aggressively cop your thumbs backward to form an L shape to bear the child's weight, and then you lift.
You are loading dead weight entirely onto those 2 thumb tendons.
You are doing that 50, 60, 80 times a day. The repeated, loaded friction of those 2 tendons grinding back and forth inside that tiny first compartment causes the synovial sheath to swell aggressively. It becomes agonizing. Every time the mother tries to lift the baby or even turn a doorknob, she experiences a stabbing, white-hot pain right on the radial side of her wrist.
It sounds debilitating. How does a physician differentiate the Quervains from a simple, generalized sprain?
They use a highly specific mechanical provocation called Finkelstein's test. If you're listening, you can try this gently. The doctor will ask you to fold your thumb completely into your palm and then close your other 4 fingers tightly over the thumb, trapping it inside a fist.
Okay, thumb trapped in a fist.
Now, keeping the arm straight, forcefully bend your entire wrist downward, away from the thumb, deviating it toward the little finger.
Wow. Even doing it gently, without any inflammation, I can feel an intense, tight stretch right over the base of my thumb.
You are forcibly dragging those 2 specific tendons through the first compartment while maximizing the tension. If that compartment is inflamed with de Quervain's, Finkelstein's test will elicit explosive, sharp pain. A positive Finkelstein's is essentially diagnostic.
Okay, before we leave the dorsum, I have a major bone to pick with our guiding principle. I want to push back on the border law, specifically the sensation rule.
Where does the law fail you?
The law states the radial nerve only feels. And structurally, the radial nerve supplies the sensory wiring for the back of the hand. But when I am manipulating an object, say I am a mechanic trying to thread a tiny bolt blindly behind an engine block, or I am just feeling the texture of a piece of silk, I am using the absolute tips and pads of my fingers. And those working pads, as we established, are powered by the median nerve. So if the median nerve is on the front, does the radial nerve truly feel the whole back of the hand?
Ah, You have stumbled right into one of the most brilliant evolutionary workarounds in the human body and a favorite trick question for medical school examiners. You are absolutely right to question it. Broadly speaking, yes, the radial nerve supplies the skin on the back of the hand. But the fingertips are a vital exception.
Why are the fingertips special?
Go back to the core function of the median nerve. It is the nerve of the precision grip. It is the biological eye of the hand. When you are interacting with the physical world, your brain demands maximum high-definition sensory feedback from the working surfaces of the fingers. You don't use the back of your wrist to read Braille, you use the tips of your digits.
So what does the median nerve do to solve this?
It refuses to yield that territory. Because the median nerve is so uniquely critical for high-resolution tactile feedback, its sensory branches traveling up the palm side of the fingers actually continue forward, wrap right over the absolute tips of the digits, and curl completely around to the back of the fingers.
Wait, the wiring from the front wraps around to the back?
Yes, the median nerve reaches over the top and stakes its claim on the entire nail bed area on the backs of the thumb, index, and middle fingers. It hijacks the territory from the radial nerve just to guarantee that the entire working tip of the digit, front and back, is wired into a high-def precision grid.
That is wild. It violates its own geographical boundary just to ensure the precision grip has perfect sensory awareness. It just highlights how evolution prioritizes function over neat symmetrical maps.
It is the ultimate pragmatic engineering solution. Okay, we have built the entire engine. We have traced the electrical wiring, we have mapped the carpal tunnels, we have hoisted the geodesic vault, and we have calibrated the marionette strings. We have arrived at the final synthesis, reading the hand.
This is the culmination of everything we've discussed. Diagnosing by posture.
Because a true surgeon doesn't need to wait for an MRI to tell them which nerve is severed. The broken machine immediately reveals itself through systemic collapse. We have touched on these, but let's formalize them. Let's start with the ulnar nerve. If a patient walks into the ER with a severed ulnar nerve, what is the undeniable visual signature?
The ulnar claw. You walk into the room, and without touching the patient, you see that their ring and little fingers are severely deformed. The main knuckles are yanked aggressively backward toward the ceiling, and the finger joints are curled tightly inward into the palm.
And because we understand the architecture, we know exactly why this happens. It isn't random. The ulnar nerve dies, so the intrinsic lumbrical and interosseous muscles paralyze. The keystones of the vault vanish, the dome collapses, the dorsal hood loses its anchor, and the massive extensor tendons in the forearm bowstring backward, pulling the hand out of shape.
Exactly. The mechanical balance is shattered. But a savvy clinician will confirm this with a brilliant active test of the ulnar nerve's motor power called Froment sign.
How does Froment sign work?
The doctor takes a thin piece of paper and asks the patient to pinch it tightly between the pads of their thumb and index finger. The doctor then tries to pull the paper away.
Okay, a simple pinch test.
But remember the border law. The ulnar nerve powers the massive adductor muscle, the muscle that snaps the thumb flat and tight against the index finger to hold something firmly. If the ulnar nerve is dead, that adductor muscle is paralyzed. The patient physically cannot squeeze the thumb flat against the side of the hand.
So they drop the paper.
They try not to. The brain realizes the primary muscle is dead, so it desperately tries to recruit a backup system. It fires the median nerve, which controls the long flexor tendon that bends the very tip of the thumb. In a frantic attempt to hold onto the paper, the patient's thumb aggressively buckles and bends sharply at the tip, digging the nail into the paper instead of holding it flat.
The thumb buckles under the pressure.
That buckling is a positive Froment sign. It proves the ulnar adductor is dead.
Incredible. Okay, that is the ulnar signature. What about the median nerve? What posture does the hand adopt when the median nerve is completely severed?
The signature is called the ape hand.
The ape hand. That is incredibly evocative.
It perfectly describes the de-evolution of the anatomy. If the median nerve is severed high up in the arm, the entire thenar mound, that thick, fleshy, muscular base of the thumb that gives the palm its shape, loses its electrical signal. Over a few weeks, those muscles atrophy. They waste away entirely. The thumb base goes completely flat, flush with the bones.
But the muscular wasting is only half the problem, right?
Yeah.
The true loss is functional.
The true loss is the defining human trait, opposition. Without the median nerve, the thumb loses its ability to swing across the saddle joint. It can no longer rotate to face the other fingers. It falls limply backward, rotating outward until it lies completely flat in the exact same geometric plane as the rest of the fingers.
It lines up with the other digits. Which brings us in a perfect brutal circle right back to our cold open challenge. Without the median nerve, the precision grip is eradicated. The saddle joint is rendered useless. The hand flattens out and literally reverts to being a paw.
Millions of years of meticulous evolutionary engineering, the leap that allowed us to craft tools and build civilizations, is completely undone by the severing of a single 3-millimeter nerve trunk.
And there's a very specific microscopic branch of this median nerve that trauma surgeons are apparently terrified of.
Yeah.
The surgical literature refers to it as the $1,000,000 nerve.
Ah, yes. The recurrent motor branch of the median nerve. It earns its nickname through malpractice lawsuits.
Explain the topography of this nerve. Why is it so vulnerable?
Once the massive main trunk of the median nerve successfully navigates through the carpal tunnel and enters the palm, it splits. Most of it continues downward to provide sensation to the fingers, but one tiny vital motor twig curves sharply backwards. It recurves and travels very superficially, sitting almost directly under the skin right on top of the fleshy thumb mound. Its sole purpose is to plug into those thumb muscles to provide opposition.
So it's sitting right below the surface in the middle of the palm.
Exactly. Now imagine a patient comes into the emergency room on a Friday night. They were washing dishes, a glass shattered, and they sustained a deep, bloody laceration right at the base of their thumb. An inexperienced, rushing junior doctor decides to aggressively clean the wound or casually blindly clamps a pair of forceps into the bloody tissue to stop a bleeding vein.
And in doing so, they snip that tiny, superficial, recurving twig.
They sever it completely. The bleeding stops, the skin is stitched up, and the patient goes home. But when the bandage comes off a week later, the patient discovers their thumb will never oppose again. The pinch is gone forever. The hand is a paw. The devastating loss of function and the resultant massive financial payout from the lawsuit is why veteran surgeons drill the location of the $1,000,000 nerve into every resident's head. You do not blindly cut into the thenar mound.
A $1,000,000 anatomical mistake. It just reinforces how high the stakes are.
Let's shift from nerves to bones. Let's do a deep dive into two extremely common, famously named injuries in the hand. The first one takes us right back to the evolutionary crown jewel, Bennett's fracture.
Named after Edward Bennett, a pioneering 19th century Irish surgeon in Dublin, a Bennett's fracture is a catastrophic failure right at the base of the thumb. Specifically, it is a fractured dislocation of the saddle joint we spent so much time discussing.
How does the saddle joint break? It usually happens when a massive axial force is driven straight down the thumb while it is partially flexed. Imagine a boxer throwing a terrible punch and landing the blow directly on the tip of their thumb instead of their knuckles, or a football player jamming their thumb directly into a helmet.
The force shoots straight down the bone into the wrist.
Right, and the force shears off the inside lip of the thumb's metacarpal bone right where it sits in the saddle of the trapezium. A small triangular fragment of the bone breaks off. But the fracture itself isn't the real problem. The real problem is the biomechanics of the attached muscles.
The pull of the cables.
Exactly. There is a massive, powerful tendon called the abductor pollicis longus that anchors directly into the base of the thumb bone. The moment the bone breaks, there is nothing holding it in place. That powerful tendon instantly retracts, acting like a giant rubber band, and violently yanks the entire main shaft of the thumb bone backward and entirely out of the saddle joint.
So the bone isn't just broken, it is actively being pulled out of alignment by its own machinery.
It is a profoundly unstable fracture. You cannot just put a cast on a Bennett's fracture and hope it heals, because the muscle will perpetually drag the bone out of the joint. The surgeon has to physically drag the thumb back into place against the force of the muscle and drill long steel wires directly through the skin, through the thumb bone, and anchor them deep into the wrist to physically pin the saddle joint together until the bone heals.
That is intense. You are literally fighting against the body's own tension system. The second eponymous injury I want to explore is Skier's thumb, which the notes mentioned used to have a much darker, much more grim historical name.
It did. It was originally documented in the medical literature as gamekeeper's thumb.
Let's explore the grim history first, because it perfectly illustrates the mechanism of the injury.
In the 19th and early 20th centuries, Scottish gamekeepers had a very specific, repetitive occupational task. When they trapped small game, specifically rabbits, they would dispatch the animals by grasping the rabbit's head, placing the rabbit's neck firmly in the V-shaped web space between their own thumb and index finger, and violently twisting and snapping the neck.
Doing that over and over. thousands of times a year.
The repetitive outward rotational force of snapping the rabbit's neck placed immense chronic stress on a vital structural tether, the ulnocollateral ligament. This is a thick, short band of tissue on the inner web space side of the thumb's main knuckle that prevents the thumb from bending too far outward, away from the hand. Decades of that specific motion would chronically stretch, fray, and eventually completely rupture that ligament. The gamekeepers would end up with chronically unstable thumbs that would flop outward uselessly when they tried to pinch anything.
A slow, degenerative occupational hazard. But today, we don't call it gamekeeper's thumb, we call it skier's thumb. Because the modern mechanism is acute trauma, not chronic wear.
Exactly. Today, the demographic is entirely different, but the physics are identical. Picture a skier flying down a mountain. They are tightly gripping a rigid ski pole. Suddenly, they catch an edge and fall forward.
They brace for impact with their hands still strapped to the pole.
The skier's hand hits the hard-packed snow, but the rigid handle of the ski pole gets trapped directly inside the web space between the thumb and the index finger. As the skier's body weight drives forward, the ski pole acts as an immovable fulcrum. It violently levers the thumb outward, bending it brutally away from the hand, far past its natural anatomical limit.
And the ulnar collateral ligament, trying to hold the joint together, just violently snaps under the extreme tension.
It tears completely off the bone. The skier stands up, tries to grip their pole again, and finds that they literally cannot pinch it. The thumb has no medial support. The structural integrity of the pinch grip is totally compromised. Like a Bennett's fracture, it almost always requires surgery to physically sew the torn ligament back into the bone using miniature internal anchors.
It is endlessly fascinating how mechanical all of these failures are. Broken struts, torn winch cables, crushed wiring, derailed pulleys. And when you step back and look at the pioneers we've discussed today, Baron Dupuytren, Fritz de Kervane, Edward Bennett, Alan Canaval, you realize the immense intellectual leap they had to make.
It is humbling. These physicians were operating in crowded, poorly lit pre-antibiotic clinics in Paris, Chicago, and Dublin centuries ago. They did not have access to high-resolution MRIs or real-time ultrasound to peer beneath the skin.
They were quite literally reading the live hand. They were observing these exact mechanical signatures, the droop of the mallet finger, the rigid buttonhole of the boutonniere, the sausage swelling of the canaval infection, the buckling of the Froment's thumb on living, breathing, working human beings. And through pure deductive anatomical logic, they reverse-engineered the internal structural failures.
Which is the entire thesis of our exploration today. You do not truly learn anatomy by memorizing a sterile list of 9 tendons in a tunnel. Memory fades. You learn it by understanding why the tunnel is rigid and how the pressure suffocates the nerve. You don't memorize the visual shape of the ulnar claw. You understand the tension dynamics of the vault and the balance of the dorsal hood, so that when the keystone is removed, the claw is the only mathematical outcome possible.
If you understand the architecture, you can reconstruct the logic every single time. We have taken an incredible journey through that architecture today. We started with a solid, homogeneous paddle in the womb, carved out by the invisible chisel of cellular death. We navigated the high-security bottleneck of the wrist, threading cables beneath unyielding roofs. We anchored the Kevlar plates of the palm, hoisted the geodesic dome of the vault, and perfectly calibrated the paradoxical marionette strings on the back of the hand.
And every single one of those staggering evolutionary adaptations, every pulley, every redundant artery, and every dedicated nerve fiber exists to serve one singularly crowning achievement.
The opposable thumb, the precision grip, the ability to dynamically rotate the saddle joint and manipulate the physical world with ultimate finesse.
It is the biological engine of human civilization.
It truly is. But understanding how perfectly adapted this machine is leaves me with one final, slightly provocative thought to end on. A thought for you, the listener, to mull over as you go about your day. For millions of years, the trapezium bone in the thumb evolved this complex saddle geometry specifically to rotate. It gave us opposition, it allowed us to thread needles, to carve arrowheads, to paint frescoes, to build the modern world.
It is an instrument designed for dynamic multi-axial rotation.
Exactly. But I want you to look at our primary interaction with the modern world today. Look at the smartphone in your pocket. Look at the flat glass screens we stare at. We now spend hours every single day, thousands of hours a year, using our incredible evolutionary masterpiece of a thumb to do exactly one thing. Tap flat glass in repetitive microscopic up and down motions. We are swiping and tapping. We are almost entirely ignoring the dynamic rotational opposition that makes the human hand human.
We are mechanically reverting the saddle joint back into a simple hinge.
We are. We are treating the multi-directional joystick like a blunt door hinge. And biology has a ruthless rule. Form follows function. If you don't use a biological capacity over evolutionary time, you lose it. If our primary daily interaction with the world no longer demands the volt's full rotational potential, how will this flat-screen, swiping world change the physical architecture of the human hand in the centuries to come?
Will the body eventually fuse the saddle joint? Will we devolve the very machinery that allowed us to create the technology in the first place? It is a brilliant, unsettling question.
Will the tool reshape the hand? It is something to think about the next time you are mindlessly scrolling or sending a text message. Thank you for joining us on this incredible anatomical journey today. Keep questioning the structures around you, keep learning, and we will see you next time.